everyone. Thank you for joining us today for the social work, addiction social work, what's new presentation. Today I am representing the social worker directors who are not able to attend. And so my name is Shanu and I am the manager for the Addictions Fellowship Program. I also just want to announce that the applications for the addiction social work and actually all of our streams are open right now. So if you are interested or if you know any colleagues that might be interested, please take a look at our fellowships website on bccsu.fellowships and shoot us an email if you have any questions. But yeah, applications are open now until December. All right, I'm pleased to announce that Collen is presenting today. Collen began her career in Island Health, where she primarily worked in community-based programs. She then moved to the Kootenays, where she's a hospital social worker in Creston. Her professional interests include improving access to services for the marginalized rural populations and supporting social workers in their practice. These combined interests brought her to the BCCSU, where she hoped to learn more about reducing rural barriers and strengthening social work practice in addictions and social work, an underserved community in this healthcare setting. With that, I will pass it along to Collen. Go for it.
Thanks, Shanu. Hi, everybody. Thank you for braving the weather and the parking. I'm not sure if anybody else had parking woes, but we certainly did. So thank you so much for being here today for our What's New in Addiction Social Work, Moral Distress in Addictions Medicine. Technically, you have to hold questions to the end, but there's such a small group of people that if you guys want to jump in with a question, if something's pressing, feel free to ask. So I do want to begin by acknowledging that the BCCSU and City of Vancouver are located within the shared, unceded ancestral territories of the Musqueam, Squamish, and Tsleil-Waututh Nations. My home and work are not here, as you heard. They're in the traditional unceded ancestral territories of the Ktunaxa Nation. And I'd just like to acknowledge that true reconciliation requires more than just a land acknowledgement at the beginning of a presentation. And I want to encourage everyone to read the TRC report, support Indigenous authors and artists, find ways to actively engage in reconciliation. And please feel free if anyone wants to do an acknowledgement or for people on Zoom, if you want to add an acknowledgement in the chat, you're very welcome. So I also want to acknowledge the drug poisoning crisis has disproportionately impacted minoritized communities and Indigenous communities in particular as a result of the intergenerational trauma caused by settler colonialism. I have no conflicts of interest to disclose. And a big thank you to the BCCSU for this incredible learning opportunity. Those of us in rural centers feel often like we miss out on learning experiences. So this has been a huge gift. And especially to the ASWF directors, Jessica and Zan, for their support. They have been amazing. And actually, Amir is also amazing. She keeps us all in line. All of the studies discussed in depth will have a screenshot of their header on the screen today. Any that are just briefly mentioned will be in my reference list at the end. And I've used images from Unsplash. They're all free for use. And my goal was to provide a counterbalance to the subject matter. So our goals for today are to review a sample of the literature related to moral distress and the impact for addictions med professionals, to consider the relationship between moral distress and responsibilization, and to reflect briefly on personal remedies to moral distress. And actually, I just forgot, Shani reminded me to let everyone know if a PA announcement goes on. I will just pause, we'll let it happen, and then, so don't be alarmed. The plan for achieving those goals for today is we'll go over the background and context a little bit, talk a little bit about what we mean by moral distress, look at a sample of the recent relevant literature. I'm going to explore the idea of responsibilization and moral distress, and then focus a little bit more into the social work specific literature. And I do want to acknowledge this is a difficult topic, and I want to encourage people to take care of themselves. So if you need to step away or whatever you need to do, I'm not talking about any specific scenarios really, but it is hard stuff. And we did have a poll, but we can't get Slido to work. So if everyone just wants to take a minute to think about what moral distress means to you, what words come to mind, and if you want to shout it out, you can. People on Zoom, if you want to put it in the chat, you can do that. Yeah, right? Yeah. Anyone else want to jump in? Injustice is a great word. Yes. Yes. Uncomfortable is great too. Yeah. Yeah. And I appreciate you being here for an hour on this uncomfortable topic. Okay, I'm gonna jump ahead. So I will share my my thoughts later on in the lecture. For a bit of background and the context from the literature. So moral distress broadly refers to suffering experienced by professionals as a result of restricted moral agency. And I feel like that definition probably resonates for everyone in this room. Elevated rates have been recently reported among social service professionals. Moral distress has been associated with burnout, post-traumatic stress, and even suicide among medical professionals. MHSU professionals report some of the highest levels of moral distress among healthcare workers, which is why I want to focus on that today. While most of us in healthcare, especially working in addictions, have heard the terms and they kind of know what they are, the reality is it's a relatively new area of study. So in the literature, the terms aren't fully settled and there is a wide range of definitions. So for today, I'm going to use the term moral distress as inclusive of moral injury, moral dilemma, that sort of thing, because there was so much overlap in the research. And in my view, they kind of exist on a continuum. So you have like moral injury at one end and moral dilemma at the other. Moral distress is sort of somewhere in the midpoint. And because the terminology is still developing, I did review a few different areas. If there was something that looked appropriate, even if the term wasn't used, I did consider it for inclusion. And the terms moral distress and moral injury were my starting point for this literature review. My primary goal was looking broadly at what the current research says about the topic, and from there, solutions to be found in the data. My expectation was that I would discuss some of the current data, followed by evidence-informed personal remedies, which sounds really simple, but what I found in the literature confounded the plan, which was a great illustration of why we do a lit review. So while there were many sources of gray literature, such as dissertations, professional association articles and things, there was enough actual quite recent relevant literature to focus on that I ended up leaving those out of my final draft. And I think it goes without saying that the issue of moral distress is an issue of critical importance in addictions medicine. While this topic isn't practice focused per se, there's no question that unrelieved moral distress is impacting our practice. We all face it. Most of us have experienced it, but in my experience, we aren't really talking about it, and there's precious little being done about it. The few personal remedies there are, as we'll see, are somewhat problematic. And so I guess that's part of my agenda here today, is to start that conversation. So the first pass of the literature revealed a stark difference between pre-COVID and post-COVID studies, which probably won't surprise anybody, not only in quantity, but also in theme. A key shift could be found in the theme of responsibilization, which while present pre-COVID became very prominent after. I will add too that while there was a range of moral distress related papers pre-COVID, once COVID hit, almost everything was COVID plus moral distress. So pre-COVID, there was like child protection social work and moral distress, or housing related social work and moral distress. But after COVID, it was all COVID. While not addictions med per se, as I said, as I was reading, the concerns felt so much the same. And so I have included some of those in this review. And I also noted that in the literature, the lens got really narrow around COVID, and now it seems to be widening again. So some of the more recent papers from 2025 are starting to be inclusive of more than just COVID. So that's also nice. And there were nearly as many literature reviews as there were studies with participants, which surprised me. So I was able to find a lot of literature from the USA, further afield. There's some from Finland, Poland, and then Canadian-based research as well. One thing I didn't see was any significant literature centering the experience of minoritized populations, and nothing highlighting the experiences of Indigenous healthcare workers, even when they were participants in the studies. An ongoing source of concern was that many of the studies had insufficiencies that rendered them only somewhat useful, which we'll discuss further on. And what was really interesting to me was the amalgamated data in the lit reviews still revealed themes congruent with even the really low powered studies. So there was a lot of homogeneity in the results. And without exception, there were calls to urgently begin more work in this field. So on that note, our first article is from 2019 and helps to clarify some of the concept of moral distress. And so we're going to use it kind of as a foundation for this nebulous area of research today. They rightly begin with a reference to Jameson, whose 1984 text appears to be the first to begin the discussion of moral distress, which develops, according to him, in a situation where one knows the right thing to do, but institutional constraints make it nearly impossible to pursue the right course of action. So this definition is noted by the author to have been insufficiently interrogated to date, and that the recent discourse in the literature reveals a range of opinions from, on one side, this is an appropriate definition, to the far end of this is absolutely inadequate, and literally everything in between. The literature review noted there are predominantly two interconnected elements to moral distress in the existing literature. So there's an event that happens that restricts a person's moral agency, and then the psychological and physiological suffering that results. They note a great deal of confusion in the literature about this, but they state that Jameson explicitly saw the phenomenon as both the experience and the result. So they kind of argue that probably should be our starting point for any definition of moral distress. They also highlight the difference between an ethical dilemma and moral distress. In moral distress, the person knows the right course of action, but they're prevented from acting on it. Some scholars take a differing view. So even in this study, this author argues for a slightly wider view, arguing that social workers have specific professional ethical principles they are expected to follow in their work. And thus it can be assumed that as holders of these principles, social workers may experience moral distress if they are unable to practice in accordance with them, which really made a lot of sense to me and probably to everyone in the room who has to adhere to a code of ethics. So they expand on this further, adding the impact of institutional constraints in their review. So one thing that was interesting, they temper this by cautioning the reader not to overemphasize the role of institutions at the expense of reducing social workers' moral agency. So, you can see it, like even in this paper, it's not super clear. So that's part of why there's definitional struggles in this field. So with this discussion, descriptions, and cautions in mind, and guided by reflexive thematic analysis, I searched for recent papers examining moral distress, but I also looked for terms that were related, such as burnout, occupational stress, and so on. My searching slowed when I reached a point of saturation. Some of the relevant literature couldn't make it in because we only have an hour, and you guys don't want to hear me talk about this for 4 hours, but there was enough literature that I could. So as I said, I thought I was going to do the literature review on moral distress and then just here's your solutions, bish, bash, bosh, we're good. But that was a much simpler idea than what the literature revealed. I ended up focusing on moral distress and responsibilization, which is not something I expected at all. In keeping with this change of plans, the next paper actually did much the same thing. So this 2025 study is the first in BC to examine moral distress and burnout among healthcare professionals working with patients with concurrent disorders. I'm going to spend a little bit more time on this because of its recency and relevance for most of us here today. And I did just recently learn one of the authors was a BCCSU fellow. So that was kind of cool to find out. This study initially aimed to evaluate systems of care for people with complex concurrent disorders with a focus on service pathways and the impacts of emerging interventions. The initial intent was to improve access to appropriate treatment services. So based on their initial readings of the first phase of interview transcripts, they actually modified the research objective and interview guide to include questions regarding burnout and the experiences of providing care. The aim of this paper then was an effort to better understand how institutional forces shape the professional practices and experiences of the participants. The interviews occurred between 2018 and 2022 with a range of healthcare professionals in the Lower Mainland. They examined healthcare professionals' perceptions of institutional constraints, which they argue produced morally uninhabitable working environments, which is a pretty loaded term. Morally uninhabitable working environments are settings in which people's moral agency is inhibited. They emphasize morally uninhabitable working environment to explicitly recognize that institutional constraints originate from healthcare and other intersecting systems, rather than just from healthcare alone, though there is plenty of representation of healthcare in it as well. They argue the importance of better understanding moral distress and burnout, and how healthcare professionals can be appropriately supported, in part because those working in mental health and substance use report some of the highest levels of moral distress. This may be due to a number of factors, including poor training, confusion around roles, and responsibilities within team environments. So they contextualize their findings through a lens of responsibilization. Sorry, guys, I have a dry mouth. They define responsibilization as the process through which institutionalized powers shift the responsibility for managing risk, ensuring well-being, and optimizing productivity onto individuals and communities. And who in healthcare hasn't felt like that's happening? They argue that responsibilization offers a valuable framing for understanding healthcare professionals' experiences by emphasizing how the healthcare system shifts the responsibility for managing institutional constraints and occupational harms, i.e. moral distress and burnout, onto workers and teams. We can probably all think of examples where we've been in this position. So when I read this, I thought of a nurse that I work with. On shift, I wasn't working. I'm the only social worker in our hospital, by the way. If I'm not there, there's no coverage. And so we had a recently unhoused, medically questionably stable patient who was being discharged. And she literally, after her shift, drove around to hotels asking if they would please admit him even for 2 weeks, just so he wasn't out in the weather. Pause.
Code blue, Provident 10 Charlie. Code blue, Provident 10 Charlie. Code blue, Provident 10 Charlie.
Okay, and we're back. And so I think for myself, even I am in a bad habit. I take Fridays off, and I've been replying to coworkers about, how do we do a Section 59 with a vulnerable adult who's, seeking their substances and left hospital, or, things like that. And then the other thing that came to mind were the ways that we debrief on our downtime. We meet up with coworkers and go for a walk and talk about our system's frustrations and things like that. And we just give more and more of ourselves until we're the ones going home, falling right into bed, not engaging with our families, not doing social things because we've spent all our energy at work. So for me, this is important for 2 reasons. The first is that the social work lens always includes structural elements. And the second was that through all of my reading on moral distress, the word that kept coming to mind was helplessness. Applying a responsibilization lens can help those of us doing the work reframe some of our sense of helplessness from a personal one to a structural one. Ultimately, the study revealed participants often perceived they had insufficient training and preparation for the realities of the job. Participants overwhelmingly described the difficulties they faced to deliver what they considered to be moral and ethical standards of care. All participants also spoke about the impacts of staffing shortages, difficulty connecting patients to services to address their medical and social needs, and experiences with direct and vicarious trauma. Institutional supports, such as debriefing and counseling, were reactive, limited, and insufficient to meet the needs. COVID-19, of course, made a bad situation worse. The problematic use of involuntary treatment also contributed to feelings of moral distress, which I think is a really important conversation in our province right now. A lot of people think it's a great idea, but they don't think about the practitioners who are behind those pieces of paper and those decisions. And violation of patients' autonomy was a major driver of moral distress. Responsibilization made these concerns worse, though it should not be considered wholly detrimental. Participants described providing support to their colleagues as a source of fulfillment, contributing to a sense of moral habitability. Other strategies they employed to care for themselves and others could be described as acts of moral resistance and influence, which could be seen as affirming their moral identities. The current moral distress and burnout interventions often focus on increasing resilience through self-reflection, debriefing sessions, educational rounds. However, their findings suggest that individual-centered strategies are often insufficient and fail to address institutional constraints. They may even perpetuate harm. Overall, this paper was very impactful and shaped the direction of this presentation. One of the papers that felt appropriate to follow with was from the USA and specific to the impact of involuntary care on healthcare workers. Before I continue, I do want to take a moment to recognize the voices of patients aren't being included here today, because the topic is how we as healthcare professionals are managing, but that's a very needed area of study, and especially around involuntary treatment. So just want to acknowledge they're not here. why I'm thinking of them. In 2022, they undertook their qualitative study to understand the use of involuntary care legislation, which is Section 35 for them, and the experience of moral distress in that context. Their interviews did not seek out responses related to moral distress. They just had an open-ended interview guide and just let participants speak about their exposure and experience. They found that although there was a spectrum in the experiences of moral distress, most participants, which was 77%, experienced some or high levels in the course of their work. There were differences in the moral distress by location and unit, but two significant modifiers appeared consistently, and they were team-based approach to decision-making and level of risk for patients. One difference between our experience in BC and theirs is Section 35 is a criminal matter, which I can't even imagine how that would compound the moral distress for participants. A significant limitation, aside from obviously jurisdiction, is that all the sites were urban, which for those of us in rural settings, you just wonder if we would have access to the same supports and services. This study also did not ask any probing questions about power dynamics between coworkers and on teams, which seemed important if team-based decision-making is a modifier. And since the literature demonstrates that a lack of power within a care team heightens moral distress, future research should definitely explore whether, for example, hierarchical decision-making leads to higher rates of moral distress. Their findings indicate a moral imperative for institutional support for evidence-based alternatives, as well as an emphasis on team-based approaches, which said to me, not just having enough staff, which none of us do, but also having the time to talk the decisions through so people aren't feeling rushed and pressured. So we're going to return now to BC to consider the impact of the opioid crisis on non-emergency frontline social service workers. So for the previous two papers focused on a range of healthcare staff, this study captured the experience of non-emergency frontline social service workers. And so perhaps not technically our target population, but definitely our allies in the work. And so they didn't explicitly discuss moral distress. This was one of the ones that ended up coming in because the themes were all the same. 14 participants in 2021 reported their stressors were a mix of feeling out of their depth scope of practice, including having to provide advanced medical aid in response to overdose, safety risks, workload issues, staffing issues, fears and experiences of violence, and of course, insufficient supports. So the authors state their analysis wasn't driven by any particular theoretical perspective, and they chalk it up to so little work having been done in the field. And they didn't obviously apply a responsibilization lens, but they do highlight statements indicating needed changes on the macro level. So housing, harm reduction supports, staffing issues, caseload issues, institutional support, such as adequate debriefing, and they really only mention micro-interventions such as self-care tacitly, so it wasn't a big focus. So this 2023 systematic review was conducted by an American research team, and they highlighted the challenges regarding terminology, especially the way the lack of clarity makes it difficult to have comprehensive discussions about moral injury and its bedfellows. They identify this as a major limitation of their review because, unlike me, they really specifically stringently adhered to moral injury. If that term wasn't in the paper, they didn't use it. I actually opted to include it because it was so comprehensive, and it also effectively demonstrated the challenges in the literature. So their study ended up being 15 articles distilled from 146 potential subjects, and they found a direct relationship between moral injury and well-being, which probably doesn't surprise anybody. But what was interesting, they found implications for both personal and professional well-being. They also found that the temporal order of moral injury and well-being outcomes remains unclear in the data, which was surprising to me. Further relationships were found between moral injury and related constructs such as burnout, trauma, vicarious trauma, and secondary traumatic stress, compassion fatigue, mental health, including depression, anxiety, and PTSD, and stress. They note that while moral injury's association with trauma was unsurprising, we actually lack a deep understanding of the nature of the relationship, and so they urged urgent research in that area. Their review also considers the impact of power in moral injury, as well as other factors such as spirituality, and demonstrates the vast impact that moral injury has. They also note a lack of theoretical orientation in the studies reviewed, and that it reflects the early stage of moral injury research. They do not conceptually illuminate how personal and professional identities contribute to the experience of moral injury as well. And then they talk also about the issue of power imbalance, systemic and interpersonal, but also that power wasn't measured in any of the studies that they reviewed. So they were surprised to find that. To address the issue of power and moral distress and theoretical framing, we are going to now turn to one of the reference papers on responsibilization. This 2023 paper is one of the few lending a theoretical frame to this literature, which makes it important to discuss. Their paper wasn't directly related to addictions medicine. It focused on the way healthcare workers often took on the burden of managing the crisis in healthcare facilities during COVID and how they risked increased stress, trauma, and burnout in doing so. And I just thought when I read it, both because it's referred to frequently and the parallels with addiction med, it felt very worthwhile to include. So this author reviewed 29 articles out of 107 considered, and she grounded it in the theoretical orientation of Foucault's governmentality studies and then drew on Rose's work around responsibilization. The author included a wide range of literature, including gray literature such as institutional docs for this semi-systematic analysis. The aim of this paper was to systematize information about approaches to self-care in the healthcare, clinical social work, and social care sectors during the pandemic, to critically review those approaches and then to propose a less individualistic, more community-oriented approach as a response to the issue noticed by critical authors. So they note that the most comprehensive definitions of self-care distinguish between personal and professional self-care. This distinction implies that there are and should be boundaries between the personal and professional selves, which should be maintained in order to attend to personal well-being. They state, however, the reverse occurred in the majority of reviewed texts, and that responsibilization too often penetrates the reasoning for self-care or mental health protection. And so it's presented as self-care taken, but for the sake of continuing to do your job or to take care of others, not simply to take care of yourself. And so there are three main reasons to focus on this paper. As I said previously, part of the social work lens always includes the structural. It's part of our training from the very beginning of our education, and it's a critical aspect of Canadian social work practice, even entrenched in our professional values. I also think we have to take care of ourselves while we push the system to change. And if we don't have the language we need to articulate our experiences or the concerns, or we don't understand the nature of the system or the needed changes, we can't do that. And because people are struggling more than they have to because of responsibilization. So that goes back to naming it. So one illustration I can share is on my home team during team meetings or problem solving, our PPL, so it's our practice lead, is constantly asking if something is a systemic issue that we can't solve, or is this an issue we actually can solve? And so not only does it help us reframe the work we're doing, but it's really permission giving. So having leadership like that minimizes harm to ourselves, which is supported in the data. So these authors advocate for a healing justice framework to replace the current neoliberal model, arguing for a community care model that complements and strengthens critical approaches to self-care. So they bring their paper back to Foucault, noting that too often the well-being of an individual is not an aim in itself, and that this renders self-care another task to be completed in the pursuit of one's work rather than for one's quality of life, which is a perfect example of responsibilization. So while I was not surprised to see the relationship between structural issues and moral distress, I think any of us probably would have predicted it, I was surprised to see it so clearly reflected in the literature. And so, as not to continue belaboring the point of responsibilization, and because of the relationship between social work practice and power issues, I will now share a sample of the social work specific literature. So this paper is from 2018. It's outside the ideal date range for the SLIT review, but its Canadian focus and clarity about the topic made it an appropriate place to begin the social work specific review. It's also a foundational paper that's often referred to. And I love that it's Canadian, but it's in international literature. They begin by stating that while social workers value helping people, they are frequently blocked from doing so because of institutional constraints, both within their workplace, but also within organizations to which they're trying to refer people. And that these constraints can also conflict with our code of ethics, as the constraints make it difficult, sometimes impossible, to help patients obtain what they need. So it was interesting to note that the authors actually identified a claim that social work is less often studied than other disciplines in moral distress research because the outcomes of decisions in other disciplines are more dramatic and concrete, whereas social work, the consequences are more often less tangible. However, the authors countered that this reason is implausible by dint of the work we're doing. Moreover, social workers' experience in moral distress is worthy of attention, not only because few studies have been undertaken, but because knowing its cause, as well as the support structures that could help lessen it, will help address the issue before the impacts to individual social workers and the profession as a whole become irreparable. And I don't know about you guys, but we're having a really hard time staffing social work positions because it's really hard work. So the qualitative description, that paper is a qualitative description, explores the causes and impact for the causes and impact of moral distress for the 10 participants. They were purposely selected healthcare social workers in Alberta. While all the participants acknowledged experiencing moral distress, they reported frequency as varying from rarely to daily, with most participants stating they experienced it a couple of times a month, which is still really a lot. Causes of moral distress generally fell into one of 4 participant-generated themes. So other healthcare professionals, which kind of made me laugh, caseloads, external resources, and internal rules. The most frequently reported effects of moral distress were by far exhaustion and sleep disturbances. Some reported they would go straight to bed when they returned from work. Most participants reported that they had trouble falling asleep or staying asleep, and that they were actually ruminating on specific instances that were causing them distress. Participants also reported experiencing emotional responses such as anger, frustration, disappointment, and sadness. It was affecting their family and personal lives, so they were needing to distance themselves. They found that they also were distancing themselves in patient care, especially when they felt that there was something that would just be unachievable. 7 study participants said that they had considered leaving a position. 5 reported they had left a position due to moral distress in the form of having been unable to fulfill their role competently, and they left due to various constraints. Time constraints were a major factor in managing moral distress for participants, which I thought was really interesting. So they positively rated peer support, but then said they often didn't have enough time to actually effectively engage in it. They also noted, which I think is also really important, there was an emotional labor load in explaining your circumstances and why it was distressing to an outsider. So you bring in like therapists to debrief a team, and then you have to explain how healthcare works, because no, you can't just take a moment to breathe deeply in the hallway for a minute or whatever, and so that was a big theme in this paper. They did report self-care strategies were useful to them, as was setting boundaries, and we'll talk a little bit more about that in a minute. Recommendations in this study were made collaboratively with the participants. You guys, I'm laughing and you're going to laugh when you hear what they were. I agreed with them in principle, but if anything, I think we've gone in the other direction. So their recommendations were to increase staffing, decrease caseload, increase education, increase time to attend things like peer support, all the stuff we know, but right. I know I read it and I was like, they're great ideas, but that's not where we are. One suggestion from this paper I would like to see implemented is they advise that healthcare teams have a social work clinical lead, and their role would be beyond the educator. So it would be to support decision-making and situations of moral distress, things like that, which I thought was really cool, because our PPLs don't have the time to do that to the degree I think they would like to. And of course, one of the biggest limitations of this study is that it was a small sample size and hand-selected sample. So this paper from 2022 also just discusses the importance of clarifying terms. And the purpose of their pilot study was to identify and just address triggers of moral distress among a sample of hospital social workers at a large academic medical center in Texas. So it was just 16 social workers recruited from a range of departments to participate in semi-structured interviews. So they described the triggers of moral distress as clinical situations, working conditions, structural conditions, and moral sources. This study also found that moral distress largely transpired from institutional issues, such as organizational hierarchies, managerial practices, and team-based communication. So macro Macro social justice issues related to insurance coverage and socioeconomic status were a big factor in this study. And I think it's something worth talking about here because we forget that insurance coverage, not quite the same kind of issue here, but it is still an issue, like especially in addictions med, when it makes the difference between someone accessing treatment and not accessing treatment. So we're not as bad as the USA in some regards in healthcare, but we're certainly not universal like we claim we are. So they note social workers are entrenched in bureaucratic policies that constrain ethical decision-making and hinder adherence to professional ethics. So like I said, while it's a US study, I argue it's applicable for us as well. And this study has limitations, but it's also important to note that it's the first in the US to qualitatively explore hospital social workers' experience of moral distress. And of course, they talked about the same kind of things like the importance of structure and good supervision, and self-care was an important modifier of moral distress as well. So this 2023 paper also comes from Texas, similar researchers, and included 43 participants from a range of ethnic backgrounds. And they found the same things. They also focused on the importance of extending prior conceptualizations of moral distress to include how personal health and safety measures and social justice concerns have become prevalent during the pandemic. So they looked at how people were limiting exposure to protect one's personal health and safety and how that impacted patient and family care. And I think that to some degree that happens in addictions med as well, right? So even just emotionally, right? We're trying to keep ourselves emotionally safe. They note that for these participants, moral distress and well-being are connected to ethical workplace culture. Their findings also looked uniquely at how moral distress in healthcare is rooted in systems that disproportionately impact historically excluded populations, including social inequities, such as financial instability and substance use. So limitations were social desirability bias and recall bias, as well as geography, and that is a very selected specific population. One of the big takeaways for me from this one was about how effective supervision can be at preventing moral distress, and their recommendation to not only ensure adequate access to supervision, but to ensure that supervisors are trained in identifying and addressing moral distress in preemptive rather than reactionary approaches. And that wasn't a common finding in the literature. And they also recommended that information regarding moral distress be integrated into social work curricula to prepare students, which would also go back to address that people go into the field and they don't really know what they're going to encounter. In short, they felt that health systems needed to show investment in social workers' health and safety and well-being, and consider how to incorporate social justice initiatives into workplace culture. So the researchers in this 2024 study drew on Lipsky's street-level bureaucracy theory, which I had never heard before, as a theoretical frame to enhance the understanding of moral injury amongst the 24 healthcare social work participants. So I opted to include this one over others because it was a theoretical frame that I wasn't familiar with and really wasn't prevalent in the literature at all. They argue this model highlights the precarious positioning and roles within healthcare which contribute to the experiences of moral injury. So street-level bureaucracy is when public service workers implement government-funded and publicly informed policies directly to their communities. These jobs often cannot be performed to the highest standards due to lack of necessary time, information, and resources. So this immediately made me think of the way the political winds shift addictions related policies every time there's new minister of health or new legislation, and it really materially impacts our work. One really interesting aspect of this study was that participants were asked to define moral injury on their own terms before they were provided with the formal definition. Sorry, I just had a little hiccup. This study also identifies the important role of social workers as bridges, connecting patients with resources, translating policy into practice, and creating links between systems to support patients. While healthcare social workers are tasked with several essential roles, we're not always equipped with the resources to do the job. This study also notes that along with high-stakes situations, moral injury relies on power imbalances, noting that power differentials interpersonally and in systems can influence the prevalence of moral injuries. They describe social workers as being positioned As the workers in between policy and practice, which I did think was apt, they go on to state that social workers are representative of the fractures in the healthcare system and often expected to act as bridges to stitch together the brokenness of systems, which was also apt. They note that social workers are often tasked with making the impossible possible and are touted as imaginative or creative workers who can find any solution to any systemic issue. While it's nice to have that acknowledgement, it puts a lot of pressure on us. And especially when we think of the high stakes alongside those fractures in services. And they note that the strength of social work education is that we gain a wide range of skills to implement with our patients, but that this strength is often twisted into a catch-all for the broken pieces of healthcare, and healthcare social workers are in turn the artists of making broken pieces of healthcare fit together again and making inaccessible services functional for patients. So reading that, the way they articulated it made me wonder about the statement previously that social work hasn't been much studied because the stakes aren't as high. What I wondered is if the stakes are just as high, but the job is so nebulous, it's really hard to quantify, hard to measure, hard to articulate. And the researchers also identified that the role of social work is nebulous, which actually leads to team integration challenges. So just because we do so many different things, and it's hard to articulate, so people don't know what to ask us for, or they ask us for things that we have to say no to because they're impossible. And that it can actually lead to an inability to consult with teams on ethical decision making, or leaving social workers feeling judged, shamed, disputed with when it comes to complex decision making. And of course, as we've already heard, team-based decision making, especially in high stakes decisions, is a protective factor against moral distress. So it's an important thing to be discussing. And I don't think it's going to surprise anyone at this point. This 2025 study also identified organizational, systemic, and policy contributions to moral distress. Their findings were pretty much in keeping with everything we've already discussed, but there was a nuance in how they discussed the two-sided nature of contributors and buffers to moral distress. So for example, our relationship with supervisors or organizational culture in this study were directly seen to reduce or magnify experiences of moral distress. So they framed it as key factors in contributing or preventing moral distress were two sides of the same coin. And then they also advise that social workers in leadership positions can experience moral distress, which is kind of obvious, but also it's not often discussed in the literature. As many of those referred to prior, this study drew from data to make recommendations for ways social workers can keep themselves safe. Given that it causes both professional and personal harm, and given the pace of change in most of even the most well-intentioned organizations can be glacial, it's imperative that social workers find inter and interpersonal coping mechanisms to manage their own experiences. The data from this study turned up a novel finding, which is that participants reported relying on their own support networks, so friends, family, coworkers, and their individual integrity to navigate morally distressing situations, which led to authors urging even more informal organizational support, such as peer debriefing, to be implemented immediately. So while it's important to acknowledge the organizational and systemic concerns, it is equally important to honor the ways in which social workers are taking care of themselves. This study was also unique in the framing of dealing with moral distress as a process that can lead to self-trust, learning opportunities, and personal growth. So they found social workers describing circumstances wherein they encounter a morally distressing event and emerge from those experiences with heightened resilience, self-awareness, and insight, which of course had a lot to do with who they could debrief with and team-based decision-making. So this now leads me to the wrap-up studies, where I do briefly share some of the personal strategies that are evidence-informed, because I did want to end on a hopeful note. And I will say here that most of those studies also recognize the paucity of literature and urge for more research to be done urgently. So, and I do, just to illustrate the importance of systemic change over each person taking on the role, there was in the first study from Vancouver, a physician noted, there's a lot of internal scaffolding type support among us, but the last thing we need, and the last thing most of us want to hear, is here's a free drop-in mindfulness session. Right? I was thinking it's one thing for us to take it on ourselves, but it's another thing for management to say, here you go with your crummy pizza. While that quote really resonated with me, the fact is there are some positive indicators attached to those personal interventions. And there would be one more poll. So if anyone wants to shout out what helps them deal with moral distress, or put in the chat, which I haven't been checking, sorry, online Zoom people.
My dog.
Your dog, me too, totally, same. Yeah, just not feeling alone, right? That's what I'm hearing. Yeah. Anyone else want to jump in? Okay. Okay, thanks. So back to what the studies say about managing. So this is a lightning round, you guys, we're almost done. This study is one of the many exploring strategies social workers use to get their work done while minimizing the harm they experienced. And so one of the things that was really interesting to me was that they explored the way social workers use covert practice strategies as a form of resistance, and that while it can have consequences for the practitioner, it appears to soothe some of the factors that contribute to moral distress. I'm happy to talk later about how we do covert practice, but we do it a lot. It's basically ask for forgiveness, not permission. That's what it comes down to. This 2021 systematic review of interventional studies cautions that while there's a lack of rigor in most studies, they reviewed. Most were single group design, low power, selection bias, et cetera, but there were glimmers of hope. And they note that interpersonal interventions do show some benefit, but they caution, of course, without addressing systemic issues. There's only so much an individual can do. So this 2022 integrative review of 18 articles also found that there's a paucity of literature regarding interventions, but still useful information to be gleaned. The results of group debriefings were mixed, but reflective practices such as journaling, especially when the participants had adequate time, were more positive. And reflective debriefing in particular was rated as useful by participants. And so I found a case study of 2, which is not a ringing endorsement, but they did draw a lot on other related literature. So, that was kind of good, but so you can see why more research is urgently needed, right? One model I did review heavily, but is beyond today's scope, is critical reflection on practice. And I'm happy to share resources about that if anyone would like. And in addition to the suite of reflective practices, the classic self-care strategies, we all know them: go for a walk, do yoga, hang out with your dog. They are actually considered helpful in reducing the impact of moral distress and moral injury. One of the most significant modifiers of moral distress is self-compassion, as this 2025 study of 572 Quebec healthcare professionals found. And I did want to do a tangent about that, but I'm just going to share the basics. So Neff was the first person really to conceptualize this. I think her first paper was in 2003, and really informed by Eastern philosophical practices. And the core tenets are self-kindness, so being kind and understanding to oneself in instances of pain or failure, rather than being harshly self-critical. Common humanity, perceiving one's experiences as part of the larger human experience rather than seeing them as separating and isolating. And mindfulness, so holding painful thoughts and feelings in balanced awareness rather than over-identifying with them. And I think given everything we've just discussed, you can see how that could be helpful. And there's really good resources. Again, feel free to reach out. I'm happy to send you lots of links. And so where do we go from here? I think further research is needed at all levels, clearly. We have good indicators of what causes moral distress, so maybe we could start focusing on prevention and intervention. And so I created a research wish list. At the macro level, I would like to understand how we make the needed institutional changes. And one study I thought would be really interesting is to subject upper management to the literature and then see how they feel about staffing levels after that. So that was, because I think sometimes if you turn a blind eye, you can just keep moving on. But if we say, no, this is the data and it's pretty homogeneous. Meso-level social work, so how teams function when debriefing time is an expectation and supervisors and or peers have training in a model like critical reflection on practice. I'm mindful this might not be successful unless it's attached to staffing levels, but this is a wish list. So, and then I would look at a pre-test, post-test evaluation for something like that. And same thing, like, using self-compassion, having some time to do some of those exercises, pre-test, post-test. And then the other big area that is lacking is research with minoritized populations. And so it would be, to me, in my ideal situation, in ways and with teams that feel safe for them. For example, it's important for us to have data about the experiences of Indigenous healthcare workers and moral distress. And I also wonder about moral distress through a cultural lens. Like, are there different experiences of providing moral distress on teams providing culturally responsive services? So that kind of stuff was just like absent. And then, of course, the other area of research that needs to be tackled urgently is healthcare workers who use drugs, especially when it's a response to moral distress. I found one study, it was a case study of 2 social workers. That was it. And I would love to see maybe survey-based research catching those who are not opting in, because most of those studies are self-selected. So what about the people who don't want to participate? What do they have to say about this topic? So what it comes down to for me, is that I think, and the data certainly supports, healthcare professionals, especially in MHSU, are in a crisis of moral distress, moral injury. I suspect this is compounded in addictions medicine by the social issues surrounding the work, but I also didn't find a lot of support for that hypothesis. While the evidence is that this is largely a systemic issue and must be addressed structurally as clear, I don't think we're going to see that happen anytime soon. So we have to take advantage of the literature pointing to the directions of caring for ourselves, not so we can get up and go to work in the morning, but most of us probably, it's a little bit of that or we wouldn't be here, but primarily so we can enjoy our lives and have fulfilling relationships. All in all, I hope today was a cautionary tale with a bit of hope, and that you learned something new about moral distress and you have a bit more understanding about it. I appreciate your time and attention. I invite your comments and questions. Thank you. I didn't stop. Oh yeah, right. Okay, references. I forgot Amir has secret slides in here. There? Okay. Any questions, any comments, anyone want to talk about anything but moral distress? Amir, how do I see the, oh yeah, there we go. Yeah, if there's
it'll be either in the chat or if you go to more, there's also a Q&A, but it'll kind of like pop.
Okay, awesome.
Yeah.
Thank you. Okay. Yes.
Just thinking about during COVID, healthcare workers would put up excellent time.
Oh yeah, the hands.
Later, people found out to work at the hospital.
Yep.
Just going from that to that. Stressful.
And when we still had the same patient burden, right? Like, it's not like the work suddenly magically was easy. It was still awful, and we were still having hot units, and yeah.
I have to research this, but sometimes message workers, moral distress, like we can manage. I think like we have tools and strategies just because of training. But often like other colleagues or professionals come into the social work office and like then we're facing some emotional labor for folks who are feeling morally distressed. And so I don't know. Some of y'all can relate to that. I think that's interesting. Such place playing it.
Oh,
Our therapists.
and for me, I feel like it comes back to we do understand the work rather than an outsider coming in, and then it's like our colleagues have to explain the nature of the work, and they're like, we were there, we get it. But you guys, one study I didn't include was they were using social work teams to debrief ICU nurses, which I thought, oh, that's really cool. And then there was no discussion about who took care of the social workers after. It was like, here you go. And I was like, I'm not including that one. It was about how effective reflective debriefs can be, but there was no follow-up. It's like, yeah, that's basically us in the literature. Yeah.
So working with social workers,
take my hat off. I'd probably give them moral distress myself. And I really appreciate that.
Well, thank you. Yes.
So the same when we have like safety incident reporting and those type of things, in the literature, is there anything like moral incident reports or anything like that? Any system that you come to?
I don't think I saw anything like that. That's such a good idea, though.
I think like just typing it out in a box that goes nowhere. It's refreshing, you know, it has-
Fill out a PSLS. Yeah. No, I didn't. I don't think I saw anything like that. It's a good idea. Yeah.
Add some extra. things.
Task.
Oh, absolutely, because we've been trying to encourage that on our team, just the amount of kind of violence that people are encountering. But it's just like, oh my gosh, it's one more thing.
One more thing, yeah.
Oh, I think of how many times I think, oh, I'm going to do a PSLS. And then you get home and you're like, I'm not going back in for that. And then you start your day and you're off and running and yeah, it's not done. I think for me, that feels like one of the things that contributes to moral distress is that those systems are so cumbersome when they're actually really important data to collect, but they don't make it easy for us to actually do it, which sometimes feels like it's by design.
I was gonna say they feel deliberately cumbersome.
Right?
Same with like the workplace health contact center for reporting workplace violence, it feels deliberately cumbersome.
Yeah.
Community thing, yeah.
You never want to call that line because you know that they're gonna call you back after you work a night shift and you're trying to.
Right. Yeah. Yeah, and I think that's a huge thing. So then we end up not capturing it and organizations can say, oh, we really don't have that problem here. And it's like, no, we're just not reporting it because we can't do the extra tasks to make sure you have it on the books.
I think if we felt like those reports had impact, we might be more inclined to dedicate that time to.
I couldn't agree more. I think that's part of the institutional issue, right? Like, and that was one thing I really liked about the study that said that they need like a social work clinical lead because that person would take that stuff on. And I think that's pretty important. Any other questions? Thank you so much. Oh, Jessica just wrote a very nice thing. Of course she did. Awesome. Okay. Well, thank you so much, everyone. I really appreciate you being here.